Greetings to one and all present here. My topic of presentation today is pre-medication. Myself, Dr. Dhanya Ravindran, Junior Resident, Department of Anesthesiology, and my guide being Dr. Savita ma'am. So, as the name suggests, pre-medication. It's basically a set of drugs that are given to a patient who's posted for a surgery, more likely an elective procedure, so as to make sure the induction of anesthesia is smooth and also to avoid certain responses, say stress responses, that can be encountered during the procedure of anesthesia. As the name suggests, it is pre-medication, meaning it is something which is given prior to the actual process of induction of anesthesia. A classic study once showed that a pre-operative visit from an anesthesiologist resulted in a greater reduction in patients' anxiety than pre-operative sedative drugs. And also children aged between 2 to 10 years who experience something known as separation anxiety from their parents on being taken away from them for the process of surgery may benefit from pre-medication administered in the pre-operating holding area. So why exactly do we require pre-medication? Now we all know that coming to an OT atmosphere from a normal surrounding might be quite scary for the individual, not just children, be alone, adults as well. So these group of drugs that we administer in the name of pre-medication, which normally involves an opioid analgesic, an antiemetic, and benzodiazepines, generally help in allaying anxiety and fear. They provide sedation to the patient. Also, many of them have anticonvulsant properties. They induce some amount of amnesia in the patient. Also, it helps in enhancing the hypnotic effect of the general anesthesia drugs that we would be administering later. And also, it ensures that less amount of volatile and intravenous anesthetic agents are used in the course of surgery. So, basically, provision of pre-medication ensures that the induction of anesthesia is smooth. Also, stress responses encountered during the process of anesthesia can be blunted. Also, further ahead, when the patient is continued under volatile anesthetic agents or say intravenous anesthetic agents, the necessity or the amount of drugs required will be decreased. So basically we can say that it does help us allay the whole principle of polypharmacy. Also, it reduces post-op nausea and vomiting, helps in the reduction of aspiration, and also it prevents the patient from the psychological trauma. Say suppose the patient is not sedated well before the induction of anesthesia, taking the patient into an OT room full of machines and modules and say a big laryngoscope and all that itself can psychologically upset the patient and actually increase his systolic blood pressure and heart rate, etc. So provision of pre-medication ensures that all these responses can be blunted. Okay, now coming to the point, is it only drugs or are there non-pharmacological ways of provision of pre-med? So basically pre-med is generally consisting of opioids commonly used being fentanyl, morphine, pethidine, meperidine, group of benzodiazepines which include Diazepam, Midazolam, lorazepam, and also we provide anticholinergics, mainly atropine and glycopyrrolate. Also providing good assurance to the patient, building a good rapport with the patient helps in allaying their anxiety and fear. What best rather than support or rapport from a doctor? Being the anesthesiologist himself will be better for the patient. So, first and foremost, even before the application of pre-med, what we should do is call the patient by his name, address him by his name, assure him that the process of anesthesia is going to be smooth. Assure him, try to allay his anxiety and fear, give him some kind of knowledge about what mode of anesthesia you're going to be applying to him. So that itself keeps the patient relaxed. Now coming on to the actual pharmacological part of it. So, like I said, the three main drugs that we're going to deal in pre-med is going to be opioids, benzodiazepines, anticholinergics and antiemetics. So, benzodiazepines. So, as you know, these are drugs which give synergistic action with anesthetic agents, opioids and alpha-2 agonists. So what benzodiazepines do is they can also potentiate the action of the anesthetic agents that we'll be giving later, and hence decreases their dose requirement. So benzodiazepines actually are GABA facilitatory. You would have heard of GABA. So what benzodiazepine does is, GABA itself is what is an inhibitory facilitatory, it helps in inhibitory facilitation. So these benzodiazepines, they potentiate GABA A receptors in the cerebral cortex, and this is how it helps the sedative, hypnotic, anxiolytic and amnestic activities that they have. So they are basically GABA A acting. What they help is they cause hyperpolarization of the cells, increase chloride conductance and bring about the action. Now coming to the main drug that we use in the OT generally, it is Midazolam. Firstly, it was discovered in 1976. It's the most avidly used benzodiazepine in the preoperative period. You can administer it intravenously, orally, intranasally. For pediatric age groups, it's tried rectally and intramuscularly. This drug has a high first pass metabolism. As you guys know, first pass metabolism is if you're taking the drug orally and then it passes through the gut, okay, there'll be a major amount of it undergoes clearance, and finally what is absorbed by the plasma is going to be decreased. And it also has a high lipid solubility. So what happens? It gets rapidly distributed in the body, because of which it has a short duration of action. Also in the plasma, how you're going to find this drug? It is going to be highly protein bound. Okay, also the T half of this drug is decreased in elderly patients. Why? Because of the reduced hepatic flow, which means a smaller amount of the drug is enough for provision as pre-med in elderly patients and metabolized by CYP3A4 liver enzyme. And the metabolite which is produced, which is 1-hydroxymidazolam, has 50% of its potency. Now what all does midazolam result in? It decreases CMRO2, which is nothing but your cerebral requirement of oxygen. It decreases your cerebral blood flow. Also it is a potent anticonvulsant. So suppose we have neuro cases being taken in, or routinely also for all cases we do use midas as pre-med. Okay, so any neuro case which is taken in, or you know this patient is of PIH, she's thrown seizures, it is always good you have an anticonvulsant in hand preparatory. Also administration of this, not for a pregnant patient but any other neuro case, would help ensure you that a provisional anticonvulsant is administered. And also it results in dose dependent decrease in ventilation. So you should always ensure that the injections that you give are given slowly. Any rapid injection will result in transient apnea. It decreases upper airway reflexes. So you should be quite careful when you do this, because you should be ready with other protective equipments for the patient. Okay, benzodiazepines, especially in induction doses, it depresses the SVR. So basically it decreases the blood resistance, systemic vascular resistance, and hence brings down the blood pressure. This effect is quite minimal as there is some preservation of hemostasis. But say for example the patient is already hypovolemic, okay, this will cause more pronounced effect, and overall it's regarded as hemodynamically stable agents for induction. Okay, so it will help in sedation and anxiolysis preoperatively. IV sedation, the onset would be about 30 to 60 seconds. Peak action is achieved in 5 to 6 minutes, and it will be lasting for about 15 to 30 minutes. The induction dose that we use is 0.1 to 0.2 mg per kg over 30 to 60 seconds. So when you're giving benzodiazepines, one thing you have to be observant is always observe the chest pattern. It is going to cause some amount of respiratory depression. It can result in transient apnea. So make sure you have your O2 supply ready. Make sure the chest rise is normal. Okay, so here's a table which is showing you in pre-medication dose, in induction dose, as infusion, what are the concentrations that you should be using. Okay, coming to the next drug, diazepam. This is something which is longer acting than midazolam. It has a high lipid solubility. Note that it crosses the placenta. Okay, and it is metabolized by N-demethylation. Some of the metabolites that are produced are nordiazepam, oxazepam, temazepam, and these metabolites also have some potency, so they'll add on to the actual potency of the drug. This results again in mild respiratory depression, decreases systemic vascular resistance, and hence the systemic blood pressure. Okay, uses 0.1 mg per kg for seizures. Specifically in lidocaine toxicity, you can use in delirium tremens, status epilepticus. But in status epilepticus, in addition with a long-acting anticonvulsant. Okay, examples of other benzodiazepines here, lorazepam. Okay, it is useful in pre-op anxiolysis. Oxazepam, it is useful in the treatment of night awakenings. Okay, alprazolam and clonazepam. Clonazepam, control and prevention of myoclonic seizures and infantile spasms. Okay, and temazepam in the treatment of insomnia. So coming on to antagonist. Do these benzodiazepines have an antagonist? Yes, they do, which is nothing but flumazenil in the dosage of 8 to 15 micrograms per kg. So here's a small table showing the benzodiazepine pharmacokinetics, discussing with the induction dose, duration of action, protein binding capacity of the drug, clearance and elimination of the drug. Now, side effects. Anaphylaxis is there but extremely rare following the administration of a benzodiazepine. So this is where the part of having an effective pre-op evaluation of the patient helps, because it is important to know if the patient is allergic to any kind of these pre-medications. Okay, also it can cause pain, thrombophlebitis, okay, following an intravenous injection, especially diazepam. So also it is given in the diluted form, and also slow injection is preferred. Now what is the reason why diazepam causes so is because of the organic solvent in it, which is nothing but propylene glycol. Okay, but midas, as we know, comes in water soluble form. Okay, generally does not result in that kind of an action, but sometimes it does cause burning with injection due to its acidic formulation. Okay, so that covers benzodiazepines in a short way that you all need to understand. Now we go on to opioids. Okay, we all are aware of the potential pain relieving or anti-nociceptive activity that opioids can result in. Okay, so as you all know, the word morphine, it is one of the opioids all of you all are familiar with. Okay, morphine, the word itself is derived from the term Morpheus. Morpheus is Greek god of dreams. Okay, so it is this dreamy state or state of pain relief or state of endorphin rich state that the drug is going to take you to. Opioids bind to specific receptors located throughout the central nervous system and other tissues. So going a little bit detail into the opioid pharmacology, if you can recall from your pharma classes, they are identified as major receptors: mu, which has mu1 and mu2, kappa, delta and sigma. So these opioid receptors, they actually couple to G proteins. Okay, and any agonist binding to this causes a membrane hypopolarization, and it results in what? Inhibition of so-called AMP. Okay, how? By inhibition of adenyl cyclase, which is necessary for AMP concentration. Now, opioid receptor activation inhibits the presynaptic release and postsynaptic response to all your excitatory neurotransmitters. For example, substance P, which is a nociceptive product from your nociceptive neurons. Now, here is a classification of your opioid receptors showing the clinical effect and the agonist at that particular point. So, mu, kappa, delta, and sigma, as you can see, mu generally results in analgesia, mu 1 respiratory depression for mu 2, okay, kappa for sedation, and delta analgesia, okay, also it is epileptogenic behavioral, sigma dysphoria and hallucinations. As you can see, morphine acts at mu and at kappa receptors, okay. Now, opioid receptor activation inhibits presynaptic release and postsynaptic response to these excitatory neurotransmitters. So, it has vagus mediated action. So, what will it cause? Obviously, bradycardia. Also, as a result of this, your arterial blood pressure falls. Also, decreased sympathetic reflexes are ensured. Now, these also result in partial pressure rise of carbon dioxide. Okay, and it blunts the response to a CO2 challenge. Now, this is because of the opioid bindings to neurons in the respiratory center of the brainstem. Okay, also it results in effective bronchoconstriction. Okay, so in general, also it results in effective blunts bronchoconstriction. In general, opioids reduce cerebral oxygen consumption, cerebral blood flow, cerebral blood volume, intracranial pressure, okay, but to a much lesser extent than barbiturates. Also, it results in the stimulation of medullary chemoreceptor trigger zone, okay. That is why it results in opioid-induced nausea and vomiting. So, here itself you see, one pre-med that you provide is going to result in some other adverse effect. That is why we have another set as an antiemetic with us, so that this response can be terminated. Okay, it slows the gastrointestinal motility by binding to the receptors in gut, and it reduces peristalsis. Okay, so there are two opioids which are newer, tapentadol and cerebranopedol. Tapentadol, it activates the mu opioid receptor. It inhibits the neuronal uptake of NORAD, whereas cerebropentanol is an opioid with similar affinities. Okay, and it ensures nociception by acting on the orphanin FQ receptor. So when an opioid is injected into your venous system, what happens? There will be initial rapid peak rise in the plasma concentration. Then it will rapidly enter your organ systems with high blood flow, so brain, liver, kidney, from which plasma drug concentration rapidly drops, followed by a slow drop due to redistribution to organs. Okay, and most opioids are metabolized through liver. Okay, either by what? It is either by phase 1 reaction by cytochrome P450 enzymes, or phase 2 reactions, that is by conjugation. Metabolism occurs at other sites as well, such as GI tract, kidney and brain. So coming to the commonly used opioid that we use in the OT, which is nothing but fentanyl. Okay, and this is a very avidly drug avidly used in our OT. It is about 100 times more potent than morphine. It is used during anesthesia to dampen the cardiovascular responses to noxious stimulation from laryngoscopy, intubation, skin incision and surgical stress. On an average, the requirement of inhalational anesthetics in propofol, okay, which is an intravenous anesthetic agent, it is reduced by about 50% when administering up to 1.5 to 3 mics per kg IV fentanyl. So here is a chart summarizing the uses of opioids for you, okay, where I've mentioned morphine, fentanyl, sufentanil, ramifentanil, alfentanil, what we commonly used in the OT amongst this is fentanyl. Okay. Now coming to anticholinergics, this should be something very familiar to you. Okay, they are esters of aromatic acid combined with organic base, and the ester linkage is essential for what? For effective binding of the anticholinergic to acetylcholine receptors. Alright, and this competitively blocks by binding acetylcholine and it prevents receptor activation. So, pharmacological characteristics of the anticholinergic drugs are mentioned here, and what it results in is also given. Atropine, scopolamine, glycopyrrolate. We mainly use atropine and glycopyrrolate here. So as you can see, tachycardia, bronchodilation, sedation and anti-synagogue effect. So you can see anti-synagogue effect is maximum with glycopyrrolate. More of tachycardia is caused by atropine. More of sedation is resulted from scopolamine. Now glycopyrrolate is a synthetic product, okay? It is a quaternary ammonium product that differs from atropine in being a quaternary amine and having both cyclopentate and pyrimidine moieties in the compound. Dose of Premed is 0.005 to 0.01 mg per kg, up to 0.2 to 0.3 mg per kg in adults, and in the injection form that is available in the OT is 0.2 milligram per ml packet is what we get in the OT. It is a very effective anti-synagogue when given IV or IM. Potent inhibition of salivary gland and respiratory tract secretions is the primary rationale for using glycopyrrolate as a premed, and heart rate usually increases after intravenous administration, not intramuscular administration. Also, it has a longer duration of action than atropine, that is 2 to 4 hours versus the 30 minutes intravenous administration. Atropine is a tertiary amine, okay. Commercial mixture of atropine is racemic in nature, and as premed it is administered intravenously in the range of 0.01 to 0.02 mg per kg, okay, up to the usual adult dose of 0.4 to 0.6 mg is what we give. Okay, so 1 ampule of atropine that you get in the OT is an ampule of 1 ml which has 0.6 mg of atropine. The larger intravenous doses up to 2 mg may be required to completely block the cardiac vagal nerves in treatment of severe bradycardia. Okay. Atropine should be used cautiously in patients with narrow angle glaucoma, prostatic hypertrophy or bladder neck obstruction. Now we were talking about how opioids itself can induce some kind of emesis, right? So now to prevent vomiting or to prevent emesis, we have the following drugs, okay? Metaclopramide, ondansetron and ranitidine. So metaclopramide, commonly known by the trade name of Perinom or Reglac in the OTs, mechanism of action being it acts as a peripherally as a cholinomimetic, okay, that is facilitates acetylcholine transmission at selective muscarinic receptors and centrally as a dopamine receptor antagonist. So it has a prokinetic agent activity in the upper GI tract, okay, and is not dependent on the vagal innervation but is abolished by anticholinergic agents, and it does not stimulate secretions. An adult dose of about 10 to 20 mg of metaclopramide is effective orally, intramuscularly or intravenously, and again I am specifying injected over 5 minutes. Okay, and during chemotherapy to prevent emesis, larger doses 1 to 2 mg per kg have also been used. The onset of action is rapid following the parenteral route of administration within 3 to 5 minutes than compared to the oral administration 30 to 60 minutes. Because metaclopramide is excreted in urine, it should be decreased in patients with, its dose should be decreased in patients with renal dysfunction. Okay, rapid IV injection may result in abdominal cramping. Alright, so it is contraindicated in patients with complete intestinal obstructions. It can induce a hypertensive crisis in patients with pheochromocytoma. Why? because it will release catecholamines from the tumor. Other adjuncts commonly used ondansetron, okay, 5-HT3 receptor antagonists they are. So they inhibit these receptors which are located peripherally, generally abdominal vagal afferents, and centrally chemoreceptor trigger zone, which is nothing but your CTZ of the area prostrema, and the nucleus tractus solitarius appear to play an important role in the initiation of vomiting and reflex. So the 5-HT3 receptors in the CTZ area, okay, they lie outside the blood-brain barrier. Now the trigger zone is activated by substances such as anesthetics and opioids and signals the nucleus tractus solitarius, resulting in so-called PONV, post-operative nausea and vomiting. Okay, so provision of antiemetics either during the pre-med time or before weaning off from anesthesia will ensure or will provide good anti-emesis. Now, why premedication? Coming to our points again, it will allay anxiety and fever, it reduces salivary secretions, enhances the hypnotic effect provided by the general anesthetic agents, okay, produces amnesia, attenuates vagal reflexes, and attenuates sympathoadrenal responses or stress responses caused during the surgery. Thank you.